Hey everybody, it's Adam Farkas along with Paul Farkas.
Hello everyone.
And welcome to another edition of ODWire Radio. And today, Paul, I would like to thank our sponsor once again. It is Marco. And
a terrific company.
Yep.
Can't say enough about them, and their instruments speak for themselves.
That is true. And Paul, you have a multi-decade relationship with Marco, don't you?
More decades than you want to know about.
So you guys go back a long way before Marco actually started getting into the really high-tech instruments. And today's talk is all about those high-tech instruments. If you heard part one, we had John Warren here talking to us all about how he automated the workflow in his office. And John Warren, if you don't know him, you probably have used his software before, actually. John owns a private practice in Racine, Wisconsin, where he's practiced since 1992. But more importantly, what you probably know him for is that he is the co-founder of Revolution EHR. So there's a probability that you're using his software every day in your practice. And John, thanks so much for being here again.
Sure, it's a pleasure.
So today, in our second talk, we're going to talk about Wavefront Technology. And before we start, Paul's shaking his head.
I hate Wavefront. I'm getting seasick. What is that?
Yeah. So we have to confess that Paul and I know not just nothing, but less than zero. Minus. We know nothing about Wavefront Technology. So John, we are starting from scratch. So we're relying on you to tell us the truth.
Well, that's good. Then I can get away with all kinds of things today.
So John, can you just sort of define and describe Wavefront Technology for us?
Sure. I started practicing back in 92 when topography was a big deal. I mean, that was like the cutting edge thing as far as measuring our patient's optical system. We're going to measure the cornea in ways we never could before. And, that certainly plays a big part in what we look at with Wavefront Technology. One of the things we've known for a long, long time is that the cornea has different refractive powers from the center of the cornea to the outside and maybe from the top to the bottom if you look at a keratoconic patient. And then also that the lens can have an effect on prescription. I don't think in 92 we had any idea the effect that it would have on not just sphere but cylinder and other types of refractive problems. As most of us know that are optometrists, ophthalmologists, or technicians that refract, we deal in sphere, cylinder, and axis every day long for our patients, and we're basically working on first and second order aberrations that way or refractive error. Using a typical diagnostic technology, we really don't have any way to look beyond first and second order aberrations. A lot of technology now does allow us to do that, and it allows us to get a much better, vibrant, and accurate picture of our patient's refractive system than we ever had before. Aberrations such as spherical aberration, coma, and trefoil are, actually pretty frequent issues that our patients deal with. Sometimes it's minor enough that a patient still sees 20/20-ish, or they're 20 happy-ish, even though they have some of these issues going on. But a lot of our patients, if you know about these issues, you can deal with them in different ways, whether it would be surgically, it would be by modifying their spherocylindrical prescription, or it would be using a specific type of contact lens, a gas perm for a very aberrant system, or maybe just an aspheric soft contact lens to deal with spherical aberration. Spherical aberration is basically where the spherical component of a person's prescription changes from the center of the pupil to the outside. It's actually fairly common, and it's something I pick up on every day and will discuss with patients, and sometimes not make any changes depending on the degree of spherical aberration, and sometimes have them with a second prescription or modifying their primary prescription based on it. Coma is something we run into mostly through corneal change, usually through a disease process, keratoconus or pellucid degeneration, or a poorly fit high-writing gas-permeable contact lens. We'll see that. And trefoil is something I see mostly in my patients that have lenticular changes. So a patient with early cataract sometimes will manifest trefoil. They kind of used to jokingly be referred to as the Mercedes-Benz symbol because that's what the surgeon drives when he takes the cataract out. But it gives you almost, instead of a 90-degree separation on your cylinder, it actually gives you three components to the cylinder, and looks sort of like a Mercedes-Benz symbol, so hence the joke.
Right. So is this more of a problem with people with normally large pupils?
The spherical aberration tends to be. The older patients tend to have smaller pupils, and I see less spherical aberration with them. But also in those patients, sometimes they'll have the trefoil, and the small pupil concentrates the effect and bothers them even more than when the pupil's larger. So the answer to that is kind of yes and kind of no. In the younger population, spherical aberration is by far the most common thing we see, and people that have larger pupils will tend to experience it more. But it's not solely something that happens in patients with larger pupils.
Right. So what sort of additional instrumentation is required for this?
We need to use an aberrometer to measure the wavefront aberration of our patients. It used to be the Hartmann-Shack model that was, research only, and then at first was used just to drive refractive surgery procedures. But now the device, the OPD3 by Marco is the one that I use, and it delivers a wealth of information very quickly that I use to start and in the middle of and at the end of my refraction process. To the point that they've actually come up with the term XFRACTION versus refraction because of the data that we're using. But it captures auto-refraction values, not just a value, but a central, a 3 millimeter, and a 5 millimeter value, which it then sends to the refraction head either as the central value or as what's called the wavefront optimized value, which will blend a little bit of the sphere and cylinder power to send over there at a 4 millimeter zone, which actually is typically much more accurate and much closer to the final refraction than the value you get from a central auto-refraction. It also gathers topography, pupil sizes, both photopic and mesopic, and then also an eye image. So I get a wealth of information about the patient's visual system. I like to describe it to the patients as I now have your optical fingerprint. When I show them the optical path difference map, or you can think of it as the wavefront map, and it shows me different power values at different portions in the cornea, and I tell them not everyone who's a -2 is the same. Most -2s are all a little bit different, and this lets me know what kind of -2 you are. So by using the OPD, I can gather a wealth of information about the patients very quickly.
Right. We mentioned in the first part of our talk, we talked all about your workflow. How do you actually work this wavefront data into your workflow in your office?
One of the first steps that the patient goes through in the encounter is having the OPD examination performed on them by the technician. And in about 30 to 60 seconds, maybe a little longer if the patient's just not real cooperative, all that information is gathered. And then that data is sent over to the refraction system so that I have an auto-refraction value to start with. And I also have the lensometry value, and I also have what's called the nighttime auto-refraction. So I really have three values to look at as I start the refraction. And it all stays tightly encapsulated and moves from point A to point B through a data cable, so there's really no staff intervention. No one has to manually dial things into this phoropter. It automatically sets itself up right away for me. So when I start the refraction, it's where it should be. So it's actually an efficiency boost to gather this data and send it over because I've got the data at my fingertips when I start that refraction.
Well, how having access to all this, how does this change the data for your refraction? Does it actually change the prescription?
In two ways, Paul. One is that I've got viewer software that lets me review all of the findings from the OPD3 either in my private office, which I will usually do before I go meet with the patient and start my portion of the exam, or I can pull it up in the exam room and review it, and then if I want to do a show and tell with the patient, I can show them here's your optical fingerprint and here's why you don't see well at night. I mean, patients are blown away when I'll before I even examine them, I'll talk to them and we'll do some of the history, and I'll say, I bet your night vision kind of stinks, doesn't it? And they look at me like, how did you know that? And I'll say, well, I can see right here that, in the center of your pupil, you're a -2. At 3 millimeters, you're -250. And at 5 millimeters, you're actually a -275. So depending on how big your pupil is, you have a different refraction. And, that's one of the ways that it actually changes the refraction that I come up with. The other is that by starting with the wavefront optimized refraction, I'm so close to their final prescription that it's usually a sphere check that I'm going through, sometimes a cylinder check, as long as they have a clean enough optical system. Now, I also have data displayed that shows me what's called the root mean square for the 3 and 5 millimeter zones that were measured. And I know that if those values fall outside of a typical range, this patient probably doesn't see as well as you would think they would see. So it helps me set my expectations at the beginning of the refraction and helps prevent me from wearing the patient out with a 5-minute refraction on the right eye, when the root mean square value at 3 millimeters is a 1.2 and normal is 0.3. So It changes the refraction as far as how I approach the refraction, and it changes the experience for the patient because it's much quicker and much more easy. As I alluded to, I also have these three pieces of data. I have the lensometry, I have the standard auto refraction, and I have the nighttime auto refraction, which is basically typically the most minus or least plus refraction the patient has. And I can show the difference between all three of those prescriptions to the patient in about a quarter of a second. So I can finish my subjective refraction, and then with both eyes open, I can say, now tell me if it's clearer this way, and I'll hit the lensometry button. It'll throw in the lensometry finding, or this way, and I'll hit the subjective button, and it drops in the today's refraction. And these patients a lot of times will say, "Oh, wow, that's clearer." I'll say, "Well, great. That's you're going to see that much clearer through your new glasses or through your new contact lenses, whatever I'm going to do to make them see better." Or for the patient that says, "No, it looks exactly the same," I say, "We're not changing your glasses this year unless you want something that looks different." The other thing is for patients that show a significant night vision shift that go from a -2 to a -275, I can kill the lights and talk with them for just a minute to let them dark adapt, and then I can show them their vision through their standard refraction, and I can show them their vision through either the nighttime auto refraction, or I can refine that refraction to show them the difference. So patients have an idea of how much of a difference a separate prescription for driving in low light situations might make for them. Or sometimes I'll just blend the prescription. If they're a 25-year-old and they go from a -2 in the center to a 275, instead of giving them a 2, I might give them a 2 1/4. And frankly, I think we've been doing a lot of that just through, knowing our patients. We've been over-minusing them by that patient. We've been over-minusing them by a quarter probably, or maybe a half diopter to make up for that night issue, especially if you refract with the lights on. I do all of my refractions. I do all of my refractions with the lights on. I don't refract in the dark. When you refract in the dark, it tends to cause you to over-minus patients because you're getting a bigger pupil. So knowing all these things has caused me to change my refraction quite a bit, but I think for the better.
So when you have a patient that has specific complaints about night driving, possibly a truck driver will say that does a lot of overnight, complaining about night driving, would you give them a special prescription, assuming they're presbyopic by that time? Would you overcorrect them for night driving and have a dedicated pair of glasses for when they were going on a long haul?
I would give them a dedicated pair of glasses, but I wouldn't be overcorrecting them. I would not be undercorrecting them, which I'm not trying to play semantics, but our prescription has the potential to change dramatically for some patients. Some patients doesn't change one bit. But it changes quite a bit for some patients. The pupil dilates. They go from a -2 to a -275, or from a +3 to a +2. It's not just the myopes. It happens with the hyperopes get less farsighted in the dark with the larger pupils also. So, by understanding this information, it really helps me drive the prescriptions. And because the OPD gathers topography data also, it not only lets me know what the cornea is shaped like and what their total wavefront is like, but it lets me subtract the cornea out and see what's going on with the lens. And this is a real help for those. And you've seen enough of these, Paul, where the patient's 62 and they see 20/25, and the lens doesn't look that cloudy. The macula is perfectly clean and the cornea is normal. And you just can't figure out why they're 20/20-ish or 20/25-ish. And you look at the lens and it's really not that cloudy. They should still be seeing better. You get aberrometry on these people, and probably 7 times out of 10, they have trefoil going on. And it's just because they no longer have a true spherocylindrical refraction. The lens is inducing some irregularity in the cylinder. And being able to know this is tremendously helpful. I'll also see patients that in the center of their full wavefront, it'll be a little bit hotter. It'll be a little bit more minus. So it'll actually be a little bit of reverse asphericity. And when you subtract the cornea out, you see that it's the lens, and that nucleus is just getting more and more dense, more and more optically dense, and causing them to actually have an island of central minus. Those patients, you explain that to them, they get the cataracts out and they come back and they're extremely happy because now they don't have the issues they had before. And those were issues you couldn't clearly identify without the technology.
Right. Now, just a little change of pace. Are you still using topography?
I do.
Decisions?
I use it in two ways. I use it, first thing I see if I see a wavefront that looks funky, the first thing I do is look at the topography. And the topography is more likely to cause these weird aberrometries, especially people with corneal degeneration or corneal warpage from contact lens wear. So I use it on its own to diagnose things, and then I also use it to subtract out the cornea to know what's going on with the lens. So yeah, I absolutely do use topography. And I use the topography, and I'll also use the wavefront for contact lens prescribing also. Patients that go from a -2 in the center to a -1 1/4 or 150 peripherally are not going to like an aspheric soft contact lens. It's actually going to make their vision worse than make it better. Whereas the patient that goes from maybe a +2 to a +1 1/4 in the periphery, you put them in an aspheric lens such as a Pure Vision or an Avera, they're going to love the vision out of that lens because they're going to appreciate the extra minus or decrease in plus out in the periphery of the lens. So it actually really helps me avoid those patients where you scratch your head and say, boy, everybody loves their vision out of this lens. Why do they hate it? I didn't even get to that point because I don't prescribe that lens or didn't even start with it.
Right. Now, basically, I would assume that this is not covered by any sort of insurance. So just the cost of this technology versus the patient benefit. Could you just review a little bit about that?
Yeah, I don't. This isn't something that always has a direct procedure code link to it, like like fundus photos or an OCT would. The biggest benefits to this really are patient management, better understanding of the patient's prescription. The closest thing to a direct ROI is the ability to make recommendations for specialized glasses or contact lens prescriptions based on findings from the OPD. But the biggest, soft ROI that I see in my practice is the efficiencies in the patient experience. We're able to, because of the data that we have, the refraction process is much shorter and easier for the patient. The patient's much more confident. And we're able to just to make things much more efficient. And then it's the wow factor for the patient. I finish the extraction with a patient and they say, we're done? That's all? You don't have to ask more questions? I'm like, no, we're ready to go. And they love the fact, we don't like to admit it, but patients hate being refracted. They hate 1 or 2, 2 or 3, and they really hate 14 or 15, 15 or 16. And by doing that, I think the patient experience has been much better. And it's actually borne itself out in the after-exam surveys that we do with patients. They tend to rave about the efficiencies and how easy the exam was and how the technology made the encounter better. So there isn't I can't run a report and say, well, I did X many of these procedures and it generated, Y amount of money. It's a little bit softer ROI, although I know that I do have a lot more patients update their spectacles than I would without the ability to show the current and the old prescription. And then also the nighttime versus the daytime prescription. So there's a kind of a hard and a soft ROI to this technology.
Right. So, John, any final thoughts for someone who's on the fence, who's thinking about implementing Wavefront technology in their office? Where should they get started, and what should they do?
Well, the simple answer is just do it. I remember when I added topography to my practice back in the mid '90s. After about 6 months, I thought, wow, how could I practice without this? And then when I added a scanning laser to my practice in the early 2000s, I thought, wow, how could I practice without this after about 6 months? And aberrometry is very much the same. After you've been having this data at your fingertips and being able to troubleshoot visual problems and other things so much more quickly and easily, which patients really appreciate, I kept asking myself, wow, how did I practice so long without this? What I would do, the thing that really sold me on it was I actually sat down and had myself examined with the technology. And I'm more interesting because I'm post-RK and I have aspheric corneas and I'm neat to look at. But I actually had the aberrometry done and I had a refraction done. And I said it was a sales rep that ran it on me. And I said, really, I'm done, Drew? That's it? And he goes, yeah, how do you see it? I said, great. And that's really what that moment is at AOA in Boston. That really is what sold me on having this technology. And I think get a little bit of hands-on experience with it and be willing to accept change. There are better ways to do things than sphere, cylinder, and axis.
So I assume the Marco shows the aberrometer at the shows?
Yeah, at the bigger shows, I've got 3 or 4 of them set up usually.
Sure.
And they usually have their product specialist, product manager there to actually dive in and show you the inside the numbers sort of things. If you're a numbers junkie, these things are for you. They generate more numbers than I even considered looking at. But what I appreciate is the graphical output, which lets me do a very quick analysis of, boy, that's normal or that's abnormal. I mean, I've looked at enough of them now that in 2 seconds I can look at the OPD and know, easy refraction, this will be quick, or, oh, geez, it's going to take a while, and open up my Snickers bar. But it's really the amount of data that it provides you and the way that it empowers you to care for your patients is tremendous.
Great. Well, John, thanks so much for sharing this with us. And if anyone has any follow-up questions, hopefully we can handle it on ODWire.
Sure.
Nice talking with you, John.
Thanks. Good joining you.
Bye.